thoracic spine, the lamina is like an articular pillar, but don't call it that, it's a lamina. And it supports the superior articular process and the inferior articular process, right? So it's spinal spinal lamina junction, then it's the lamina with the articular processes, right? And then remember the transverse processes are coming off of the lamina as well. It looks like they're coming off the body, but they're not, they're coming off of the lamina. And then the next would be the pedicle attaching all of those elements that I just mentioned to the vertebral body. Okay. And then of course, in the thoracic spine, we have ribs, so they have to articulate with the transverse process of the costotransverse articulations. And then you have either demifacets or full facets, where the rib heads articulate with the vertebral bodies. And we underestimate the importance of those, and we're missing degenerative joint disease all the time. In fact, here's one that probably has a little bit of a hypertrophy going on, and maybe this one as well. Okay, so that pretty much covers it. Okay. By the way, we in the lumbar spine talked about the pars interarticularis. You can also talk about that in the thoracic spine. It's just not as significant because we don't see, and I've never seen, spondylolisthesis of a thoracic vertebra. And it's probably because they all, between sternum and ribs and vertebral bodies, they all are connected. And so where the heck is there to go? All dressed up in no place. Okay. This is the vertebral body end plate. So the part, by the way, I should finish that off. Just in the lumbar spine, we look at the same thing, right? As we can see each through the thoracic. So that's what the collar would be, right over the but it's on the lamina, right? Okay, so inferior end plate, superior end plate. Right? Sometimes it looks like you've got a double end plate, but that's only because of, wedging of the disc. Or it could be because, it could also be in the thoracic spine. Remember we said that the anterior height isn't as tall necessarily as posterior height, and in fact the posterior height is 2 to 4 millimeters higher. So we have to take that into account if you're trying to determine whether there's a compression deformity or a fracture, anterior compression deformity or fracture to the vertebral body. And then now on the lateral, we can see our end plates, and we can see that there's invaginations that we call notochordal impression, or we call them persistence nuclear impressions as well, or persistency. Right? And we have to differentiate those from a Schmorl's node, which is like a disc lesion, right? So instead of going posterior and lateral or messing with the neuroforamen or the lumbar spine, the lateral recesses, then we can have an excavation through the, or it's not a thick cartilage, but it's cartilage nonetheless, and into the vertebral body goes the angular fibers. But it also takes other things. I mean, it could take bony elements. It takes the, Sharpie's fibers into there as well as, nuclear and material and angular fibers. So we can see a little bit of degeneration going on here, spondylolisthesis. Okay, so we talked about a Hans venous cleft. I don't think I see one here, but remember, I think we've already had that on the house. I'm going to try and remember and it's not so hard to do. I'll go back to my old PowerPoints and see what I've already tested you over. So it's not like I'm going to test you over the same material. So, you can kind of do the same, go through those PowerPoints. Well, you can't do that, can you? Would you like me to just give you the old test so you know? Okay. Okay, so anyhow, you got good memories, right? Okay, so the posterior aspect of the vertebral body sometimes is a little indentation. Don't get excited about that. And by the way, some of you people are giving me pathology, and you're, saying, oh yeah, they've got degenerative joint disease. I don't want that. That's not what this class is all about, right? So don't go down that path, I can see where, because I would do the same, maybe out of desperation, you gotta put something, I don't wanna leave it blank. So, but I'll give you kudos if you're on the money for that, but not a point. Right? Okay. So, we notice that there's a concavity on the anterior aspect of the vertebral bodies, but in essence, it's all around the vertebral body. You just can't get that perspective in looking at the sides. You surely can from the front. And to a lesser extent, we've got concavity on the back, in fact, almost looks flat, but there is some indentation, as you will see, on the transaxial. You can see that there is a little indentation. Okay, so the pedicle is this, right? It's that horizontal kind of bar or bony bridge that will form the roof of your IVF, and it also, with the subjacent vertebra, forms the floor of the IVF. And then next comes the lamina. Lamina doesn't look so big in the thoracic spine, and nor does it for the most part in the lumbar spine, because there are so many other elements that are associated with it, such as the transverse process is probably in this area here, superior articular process, inferior articular process, and again, this would be the area of the pars interarticularis, which is going to be under the transverse process, right? And here, unfortunately, you can see this one, and you can see this one, the spinous process, because of the fact that the ribs kind of do this, unless you rotate the patient, get some of those ribs out of the way, it's going to be hard to see the spinous process. What's the term that we use with regards to the spinous process when they overlap like that? Imbrication. Yeah, good, imbrication. So we can use that term to represent, normal anatomy or positioning of one spinous relative to the other. But we also talk about imbrication when this happens, right? With degenerative joint disease. And usually, if you've got slipping down with the zygapophyseal joints, you've got rectal positioning of the vertebra, posterior weighting of the disc, and there are other indicators of imbrication. Okay, so let's remember to take care of that. This gets pretty messy back here. So I anticipate that I'm going to ask you anything that's too busy back here. You should be able to identify where the transverse is, though, superior and inferior process. And then all I'm saying is that this business back here just gets too busy to be clear or to ask any questions of. So you can see all of these are all outlined here as far as what they represent on a dry specimen. Okay, so here's the example of a Hans-Venus cleft, the nice one. There's only one of all these vertebrae that we can see. Okay. The ribs sometimes get in the way and wreak a little bit of havoc. Remember that it's on the lateral radiograph now in the thoracic and the lumbar spine that you see your IVFs. What do we have to do to see the IVFs in the cervical spine?
Have to oblique.
Make an oblique. Right? Now, in the thoracic and the lumbar spine, the main reason that we're taking, it's not always the main reason, but it seems to be the reason, which is the justification for taking it, would be to see the pars and verticularis, to see if they're intact. But it's also true that some schools, they have, as their kind of routine series of x-rays, include every articulation and, try and reveal that as best they can. So it's standard for them to take their obliques because you see the articulations really well, on the oblique radiograph too. So, but here at TCC, the border obliques is because we suspect there to be usually a part of cell defect. Okay. Fair enough. This is a dry specimen. This area in here, and more on the lumbar spine, we refer to as the lateral recesses. And that's where you get, a lot of times, posterior and lateral disc herniation. You don't get it so much here, and it's because, isn't another name for the posterior longitudinal ligament? It's called a broad, R-O-A-D. We were taught that at home, and I used to work on the internet, and I tried to get the and blah, 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 and other courses in that. So just remember that as a PLL. But the reality is the PLL is very big, and it's hard for the disc material to push on, but it kind of oozes out the sides of the posterior aspect. So the PLL is a little thinner on the lateral aspect. And we refer to that often as central, but it depends on who you read what article. They would refer, rather than they would refer, that you refer to it as the right central or left central. That's beside the central. But you have to be, of course, specific and indicate whether it's right or left. Okay, so, pretty much covered it on the AP and the lateral. Okay, again, when it comes to primaries and secondaries, we know that there are 9, right, so-called secondaries. And the ones that we see on the vertebral body, they're also referred to as ring, R-A-N-G, apophyses, right? So I'm not going to put that on the test, but National Board might refer to them as ring apophyses. And when I said that with the Schmorl's node, or even with the herniation, some of that ringed apophysis could be part of what is, kind of extruding, right? Could be part of that complex of herniation. Okay, so primaries are in utero and secondaries are post neurocentral, system. I want you all to be able to draw these. Oh, here it is, the hypothesis. And that's what we're looking for. And we said that in females, probably by age 15, the spine has completed growth. Men a little bit slower, 16 or so. So there's a spread there. We can be off a year. Not sometimes 2, I guess. So, 14, 15 for the female, and 15, 16 perhaps for the male. Okay. And this is, of course, the hypothesis here. All right. So we have to make sure that this is a young spine, so we don't expect to see a lot of nuclear and notochordal impression. There's a little bit here, which is unusual because normally it's the inferior end plates and the superior end plates of the vertebral bodies are relatively flat. However, this is just an unfused ring hypothesis, right? There's one there, one there, one there, one there. So 2 for the vertebral body, and then circumferentially they go all the way around, right? And they'll encompass the center of the vertebral body. So these are both unfused because the person's young. This can very easily be confused with a limbus bone, limbus vertebra, right? Remember that one? But what would we have expected to see with a limbus bone, limbus vertebra? What one thing, one characteristic? Because really, think about it, limbus bone, limbus vertebra is like a Schmorl's node. So that means that nuclear material has gone someplace. And when it starts going someplace, what happens to the disc space? The height of the disc. It becomes decreased. So when you look at these disc spaces, there's no decrease. So chances are it's an unfused hypothesis. And so we're not so worried about a young kid having disc lesion, but it can occur without a doubt. However, if this were an adult, there's no reason why this couldn't persist into adulthood, right? And you say, oh, they've got a limbus bone, limbus vertebra. But the disc space is good. And if you do MR, right, it's going to look good too. I mean, good signal, nice bright signal, and no desquamation. So realize that sometimes it's difficult if you've got an isolated situation where only one vertebra is involved. And normally I see the limbus bone here, the superior aspect, right? But there's no reason why it couldn't be elsewhere. It could be posterior. A portion of the ring hypothesis didn't kick in and it was isolated, because of herniation of nuclear material. So realize it could be on any of the corners, right or left, and posterior. So this is just one. All right. Realize though that at some point in time, these look like they are independent, right? All 5 sacral segments, but it's unusual that you can see disc space. If anything, it could be rudimentary. How come you taking pictures of these? It's a PowerPoint. Save your batteries. Anyhow, I know what you're doing when you're taking down the review. I'm not going to. Just don't point it at me, because your camera will implode.
On the waiver.
That'd be That's one thing I've never allowed in my classes, is people, I don't mind that the audio recording, but not picture. I was Navajo, I guess, in a past life. I consider it capturing my soul, which I'm not, I've lived in Egypt. Okay, so enough about that. Now we're to the lumbar spine, first lumbar vertebra versus some of the others. You know, it's all based, the differences are based on size and